Hello everyone. In this section, we will continue to learn about upper gastrointestinal hemorrhage. Let's see something about the clinical manifestation and diagnosis of UGH. There are many clinical manifestations of upper gastrointestinal hemorrhage, which are classified into 5 major clinical manifestations. The patient may have some of them. Their performance depends mainly on the speed and amount of hemorrhage. The first clinical manifestation is hematemesis and melena. It is the characteristic manifestation. Patients usually have melena, maybe with or without hematemesis. We can imagine that when the bleeding point enters the pylori and the amount is small and slow, he may be without hematemesis. If there is a lot of bleeding in the stomach, blood may vomit through the upper digestive tract and the patient may have hematemesis. He may vomit coffee-like content, bright red blood, or blood clot. Regardless of the location of the patient's bleeding site or the amount of bleeding, most of blood is eventually discharged through the intestine. So, most patients with upper gastrointestinal hemorrhage have black or tarry stools. If the amount of bleeding is large, the speed is fast. The blood stays in the gastrointestinal tract for a short time, and the patient may also appear dark red stool. Well, some of you may have the question that why UGH patients' hematemesis is mostly coffee-like. That is because the hemoglobin in the blood under the effect of stomach acid turned to acidified hemoglobin, which color is coffee-like. Therefore, when the blood is vomited through the digestive tract under the action of stomach acid, the contents are coffee-like. However, if there is a lot of bleeding and the blood does not act sufficiently, then bright red blood or blood clots may be vomited. Black and tarry stool are also similar reasons. Iron in hemoglobin under the effect of intestinal sulfide turn to iron sulfide, which color is black, so the patient have black or tarry stool. The second manifestation is hemorrhagic peripheral circulatory failure. It is the most important manifestation of massive hemorrhage. Whether the patient have circulatory failure and the degree depend on the amount of bleeding. If the amount is more than 1,000 milliliter in a short time, one may appear dizziness, palpitations, fatigue, syncope, and decrease the blood pressure, even shock. It has high mortality rate among the elderly. UGH patients usually have anemia too. Acute massive hemorrhagic will be accompanied by hemorrhagic anemia, but it is not obvious in the early state of hemorrhage. Anemia will appear after about 3 to 4 hours, the most obvious 24 to 72 hours. We can see hemoglobin, red blood cell count, and HCT are all reduced. RET will increase within 24 hours after bleeding. Patients with chronic blood loss usually present with small cell hyperchronic anemia, while acute blood loss usually normocytic anemia. The fourth manifestation is fever. That may be because the decreased blood volume, anemia, and peripheral circulatory failure make thermoregulatory center dysfunction. Most has low fever within 24 hours and it drops to normal after 3 to 5 days. The last one is azotemia. After the hemorrhage, the digestion products of a large amount of blood protein are absorbed in intestine, and the blood urea nitrogen temporarily rise. It will rise in a few hours after bleeding, reach the peak in 24 to 48 hours, and recovered in 3 to 4 days. The blood urine nitrogen is generally no more than 14.3. Okay, let's see the next part about the diagnosis of UGH. Before we make the diagnosis, we should make sure several questions. The first question is that it is hematemesis or hemoptysis. The patient or vomit bleeding-like substance from the mouth. We should figure out whether the blood is flowing from the digestive tract. We have to ask about the situation at the time of the disease in detail and simply perform a local examination to distinguish whether the bleeding-like substance came from the mouth, nose, throat, or respiratory tract. We also need to ask if the patient has taken food or medicine that may cause black stool. For example, eating large amount of animal blood, taking medicines containing charcoal, iron, or bismuth. Then, the diagnosis of UGH should combine clinical manifestation and laboratory evidence. Clinical manifestation we have learned before, such as hematemesis, melena, hemorrhagic peripheral circulation failure, and so on. Laboratory evidence should include that the vomitus or stool, a cold blood test, is positive. Hemoglobin concentration, red blood cell count, and HCT decreased. At the same time, the bleeding factors outside the gastrointestinal tract must be excluded. In addition to the diagnosis, we also need to assess the severity of the patient. We can use the patient's clinical manifestations to assess the amount of bleeding. If the patient only has a positive facial occult blood test result and no other clinical manifestation, the bleeding volume is approximately 5 milliliters per day. If the patient has melena, then the amount of bleeding is usually 50 to 100 milliliters per day. Once the patient has systemic symptoms such as dizziness, palpitation, fatigue, etc., the bleeding volume is usually greater than 400 to 500 milliliters per day. When the patient has symptoms of peripheral circulatory failure, then the amount of the bleeding is usually more than 1,000 millimeters. Correctly assessing the patient's bleeding volume can help us choose appropriate treatment plan for the patient. In the progress of the treatment and monitoring for patients, we often need to judge and assess whether the patient's gastrointestinal bleeding has stopped to adjust to the appropriate treatment measures in time. The following situation indicated that gastrointestinal bleeding has not stopped. The first is the patient's repeated hematemesis, vomits turned from brown to red, and increased the number of stools, thin feces, from black to red, and both sounds are active. Or the patient's peripheral circulatory failure after transfusion and rehydration did not improve. Or the contents drawn through the stomach tube contain more blood. Regarding laboratory tests, the patient's HUB, RBC, and HCT keep following. RET and BUN continues rising prompts us that the bleeding has not stopped. At this time, we should properly consider whether the current diagnosis and treatment is correct and whether it needs to be adjusted. Okay, the above content is about the clinical manifestations and diagnosis of UGH. If you want to learn more about it, please join us in the next section. Bye.